In the beginning, I would like to thank to LKC for invitation. And this is a real honor to participate in spreading the knowledge about Reteval over the globe, because I think that this is really breakthrough in the diagnostics of retina, of optic nerve diseases. And after fascinating speech of Professor Chen, I would love to switch to inner part of the retina, and I'm gonna talk about photopic negative responses. Uh, Photopic negative responses are new invention actually in the electrophysiological field. However, it's nothing new about the actually recording protocols, because this is belonging to ERG protocol, extended one. And as you know, probably you work with many different various devices for electrophysiology, more or less advanced, older or newer. All of them actually measure the same. They measure the conduction and properties of the retina and visual pathways. Actually, PhNR is just another part, another way of measuring this conduction of electrical current in the retina, part of the visual pathway. And the PhNR actually focuses on ganglion cell function, ganglion cell conductivity, and it will give information about the action potential that travels through this part of visual pathway. And it is important also to underline that retinal ganglion cells themselves, they are the cells that connect the whole retinal system to the brain, to the centers in the thalamus. And in the past, before the PhNR was introduced, the pattern ERG was used to evaluate this part of the visual pathway. However, now we have the photopic negative responses, which I would try to persuade you are very useful and easier to perform. And actually, when I think about Reteval and all the development of electrophysiology and this technology for the ophthalmic use, you could, compare it to the development of the phones, of the technology of the cellular phones. And actually, Reteval is like last invention that could be compared to the touchscreen intelligent phones. So this is really the high-tech achievement in the last few years. So Reteval enables to perform some very specialized and specific tests, and photopic negative response is one of them. I think it's also important to mention that it also has protocol for diabetic retinopathy screening and also SCON protocol, which are all three quite unique for use in case of Reteval. Photopic negative responses are giving a lot of information. Actually, it would be very much simplification to say that photopic negative responses give only information about ganglion cells activity. It's not true, because I will show you in a moment that there is much more we can obtain from this protocol. And the report or printout is also very specifically constructed. In the printout, of course, you have right and left eye, and you have the panphotopic responses part, and also the photopic negative responses report. So what is a photopic negative response? Why it's so special? It's a slow negative compound that comes out in the reading in the electroretinograph after the B wave. And of course, it depends, as the name says, on the photopic response. So it's derivative from the whole retinal part of visual pathway. So in this recording, actually, we are obtaining A wave, B wave, and photopic negative response wave. However, these are not A and B wave like in full field flash ERGs, because the adaptation for this test is done with the blue light, and it's done on the blue background, and the stimulation is done with red flashes. So the A wave, actually, because we have light adaptations, are not consisting much of rod's responses, and the cone's responses are also not fully cone responses like in flicker, because we have blue adaptation, which diminish some of the cone responses. And the B wave, which is standard, of course, it comes out from the mostly on-off bipolar cells, some interneurons, and the photopic negative responses, which comes from the ganglion cells. And when the photopic negative response is abnormal, because I will show you there are many different ways to measure photopic negative responses, and we should consider them abnormal if the amplitudes are decreased, which of course is quite logical, but also something that we not often say and not often consider in case of ERGs in general. If the culmination time of this wave is longer than 100 milliseconds, we should already start looking into pathology within the ganglion cells, although the amplitudes might be normal. And there are also two ways of measuring photopic negative responses. They can be measured at the minimum value with no respect to the culmination time, or they can be read at the 72 milliseconds. However, this already, we know that this 72 milliseconds, at this point, the photopic negative responses are not very specific and they don't really reflect ganglion cells responses only. So in the original printouts, we always had the two values in the past for the photopic negative responses. They were at 72 milliseconds and also at the minimum value. As you can see, the culmination times for the minimum values were not necessary at 72. They could be earlier, they could be later. So actually, after a lot of analysis done, we already know that this minimum volume is more specific for ganglion cell function. However, we need to remember that if the minimum volume is at the latest time than 100 milliseconds, it should be considered already abnormal. So from the readouts with photopic negative responses, you can get four different types of combinations of the results. You can get normal panphotopic responses from the retina combined with the normal photopic negative responses. You can have normal retinal function with abnormal photopic responses, photopic negative responses. And also you can have situation in reverse order, that you have abnormal responses from the retina with correct, normal, or abnormal photopic negative responses. And this is particularly very important because if you consider what I said in the beginning, that PhNRs derives or they come out, their continuation of the photopic response of the retina, this is very important to understand that diminishing of panretinal responses might actually affect reliability of the readout of PhNR. And of course, when the technology was created, people who were responsible for describing and creating the device already knew about this, that the photopic responses might affect negative responses as well. So there is an extra coefficient created, which is called W ratio, which is kind of way to normalize the value of photopic negative response and make it less dependent on panphotopic responses from the retina. However, we need to remember that this is only in some sort of way normalizing the value of PhNR. But if really the panphotopic responses are diminished, the W ratio also might not be very reliable. And how we perform this test, this is actually very simple and very fast test, which is done, as I said, with the blue background, red light stimulus. And there are two types of making it as for the ERG itself. So it could be with CD or TD. For the CD, pupil must be dilated. For the TD, so Troland pupil no need to be dilated because the Reteval device provides real-time pupillography and it adjusts the strength of the blinks to the pupil diameter. And of course, we use the standard sensor strips for Reteval, and we should do at least 2 full tests and average them to get reliable response. So how the strips looks, I think everyone who works with Reteval knows. Maybe not everyone know that there are also small size sensor strips. For example, when we need to test the small babies. However, it's also important to tell that the small size sensor strips, they do not have normative values. If we run tests with the small size sensor strips, we get raw data without normative values. And what is the diagnostic utility of PhNR? Of course, the most, for this it was designed and created, diseases of the innermost retina cells, so ganglion cells, but also we can do the screening test for outer retina condition and the global retinal disorders. And this is something which I personally very frequently use when I have non-cooperative patients. I run PhNR because it's a very fast test. It's not very disturbing to patient because blinks of light are not strong. They are not bright light. And it will give you a screening information about retinal function and ganglion cell function. So this is really, I recommend if you have non-cooperative patients, especially pediatric patients, and they don't let you do much in the office, PhNR recording is very useful for the screening examination on the first visit. In the innermost retinal layers, of course, we mostly want to test glaucoma, but you need to understand and you need to bear in mind that we are measuring ganglion cell function here, and ganglion cells are dying not only due to glaucoma. So in glaucoma aspect, we of course can use it to confirm or exclude glaucoma. For early screening, we can use it also for checking effectiveness of IOP lowering treatment, and also in pediatric glaucoma for the cases that cannot perform visual fields. It's also very useful. But except this, we can use PhNR test for the genetic optic neuropathies, ischemic ones, any form of optic atrophies, diabetic retinopathy as well. And I want to share with you some cases which maybe will show you how to use in certain settings the PhNR test. So the first case, glaucoma suspect. This was very doubtful if it's glaucoma in the first contact, but it was recommended to me due to the big optic disc with CD ratio also enlarged. You can see the discs were really huge in this case. However, IOP was normal with thin cornea, so because of the risk of glaucoma development, they sent it for further evaluation. Visual fields, Humphreys, well, correct, were fine. And in PhNR also we got the nice correct responses in the right eye -10, left eye -8. So within normal limits. You can see also that panretinal responses also within limits. So you can say that the test is reliable and this is non-neuropathy case. Outer layers of the retina can be affected in case of this measurement, in case of this test, by many different conditions. The most common are ischemic disorders, retinal dystrophies, and also vitamin A deficiency. And this we need to remember because we not always consider that we have a huge population of patients with vitamin A deficiency, especially in pediatric patients that do not like eating veggies or they don't have full range rich diet, especially in teenagers or older toddlers which are picky with eating. We always need to consider vitamin A deficiency. And here you have these two situations where you have correct, like normal responses from the retina, entire retina, and diminished ones. So in such cases, you never know if the PhNR is lowered, is reduced because the output from the retina, the generator, is not working properly, or this is real case of the neuropathy. So you always need to combine it with other tests. And the clinical example, you have 20 years old male, 0.6 Snell and visual field, correct IOPs, completely diminished, or maybe not completely, but diminished panretinal responses, and also decreased PhNR responses. And such case always requires checkout with other tests, because of course we need to see how the retina looks, if there is no developmental abnormalities, and how the visual field looks. And this is very beautiful case of X-linked retinoschisis. You can see that the visual fields, of course, they have some scotomas, but of course the retina looks like in OCT attached here. So the retinal responses which were diminished comes from the genetic disease of the retina. So here there is no doubts that the lower responses from the retina are coming from the genetic disease. And another case, this is 6-year-old girl, visual field very low, visual acuity very low, IOP on the border. We know that this child has congenital glaucoma, and it was also suspected to have retinal dystrophy on the top of this. You can see that the panretinal response is very diminished, and also almost diminished PhNRs. And in this case, I would like again to repeat and to remind you, with PhNR, you always need to try to get the photopeak responses, panretinal responses, as correct as possible to see if the PhNRs are really diminished, or this is just derivative of the diminished panretinal responses. So in this case, I administer to this child vitamin A supplementation, of course, additional IOP lowering. And you can see after 6 months, the control test, after 6 months of supplementation of vitamin A, you can see that panretinal photopeak responses are already much better, which makes the test much more reliable. And the PhNR are, of course, reduced, because this is case with congenital glaucoma, but it's already not as reduced as it was before. So in this case, you can use it for follow-up to check the disease progression in this child. And I work with PhNR for some time already. So I did multiple tests. For now, I have, I think, about 1,000 recording for this test in different population of patients. And we did some statistics for our results. And what I can show you, that if you have normal panphotopic responses in PhNR test, it correlates very strongly with the pattern standard deviation from the visual fields, RNFL thickness, GCC complex from OCTs. However, when panphotopic retinal responses are abnormal, so they are diminished, the correlation is already almost gone. So this is a major take-home message from me. If you work with PhNR, you always ensure that you have good panphotopic responses, because if you cannot obtain good panphotopic responses, PhNR might not be very reliable to test ganglion cell function. So based on my experience, PhNR strongly correlates with glaucoma functional and morphological factors from perimetry, OCT, especially in absence of retinal function impairment. And weaker or lack of correlation and between the PhNR and other coefficients might limit reliability, and then it might be false test to use to check progression of the glaucoma in certain patients. However, it also might be tricky. Even with the diminished pan-retinal photopic activity, you might get recording of PhNR. So with this, I would like to end my talk, and thank you very much once more.